The topic today is nebulized antibiotic for ventilator-associated pneumonia. The first question I would like to address is what are the potential benefits of using the inhaled route rather than the intravenous route for giving antibiotics? Let's say that very easy to understand that it's to reach directly the infected lung parenchyma without crossing cell membranes. If you go through the bronchial tree, then you will reach the alveolar space. The second reason is if you do so, if you can reach the distal lung, then maybe you can reach very high concentration and have a much higher bactericidal effect. In other words, maybe you can kill much more rapidly and easily bacteria infecting the lung. And maybe the third potential benefit is that you can expect to decrease systemic toxicity because the membrane to cross is from the alveolar space to the vascular bed, and maybe this barrier offers a difficulty to cross for antibiotic, so the systemic toxicity might be decreased. Okay, these are the three main reasons why it is tempting to use the inhaled route for giving antibiotic. The first part of my talk is going to examine whether experimental studies have confirmed or infirmed this potential benefit. The second part will move to clinical studies that are not very many, to see whether these benefits are really observed in clinical practice. It is critical to start with saying that there are very strict and probably difficult to reach conditions for putting the antibiotic to the deep lung where you are using nebulization. The first is to optimize the size of aerosol particles. The second is that you will get some extrapulmonary deposition. What do I mean by that? Inserting the nebulizer in the inspiratory limb, then you will have deposition inside the nebulizer, inside the tubings, inside the endotracheal tube, inside the trachea, inside the bronchi. And this is not your target. Your target is to reach the alveolar space. So you will have extrapulmonary deposition. That means loss of dose. And the third is to focus on the type of nebulizer you should use to optimize nebulization. In all your ventilators, you have jet nebulizers. You are going to see that these jet nebulizers are not fully adapted for nebulization of antibiotics. If you want to give a bronchodilator, your target is to reach bronchi. It's well done by jet nebulizer. If you want to treat a lung infection, you need to read the alveolar space, not the trachea, not the bronchi, and it's much more difficult. So, in fact, ultrasonic, this is one ultrasonic nebulizer, and vibrating plate nebulizer are much more performant than jet nebulizer. We have published papers on that. Other groups have confirmed this paper. So, in practice, the jet nebulizer you have on your ventilator is not adapted for antibiotic nebulization. It is adapted for providing bronchodilators to the tracheobronchial tree. The second very important condition is that at least 50% and much better, 90% of particles should have a diameter above 5 microns. If they are bigger, they deposit into circuits, trachea, bronchi. Another very important point is that patients on mechanical ventilation should be perfectly synchronized with their ventilator. If they fight against the ventilator during the nebulization period, you generate turbulences and extrapulmonary deposition. Then you lose much dose that will not reach the deep lung, the alveolar space. So that, you will see in the second part of the talk, in clinical practice, during the nebulization period, you should use a short infusion, for instance, of propofol to fully adapt your patient to the mechanical ventilator. Another point is extremely important. What you should try to avoid is turbulences. If you have turbulences, then you will impact circuits, endotracheal tube, trachea, bronchi. You will lose the dose that is supposed to reach the deep lung. So your ventilatory setting should be specifically adapted to have the less turbulent inspiratory flow as possible. If you do not respect these very requiring conditions, then you may fail. You may attribute failure to nebulization. In fact, it is a failure of the conditions of nebulizations. Let's see what happened. Ultrasonic nebulizer. Then you're giving into the nebulizer chamber a dose. At the end of the nebulization, there is some Chandler deposit. So the nebulized dose is less than the dose inserted into the nebulizer's chamber. Then you will get circuit deposit, inspiratory limb, connecting tube, endotracheal tube. So the inhaled dose, the dose penetrating into the respiratory system at the end of the endotracheal tube is much less. And then you will have upper airway deposit. Again, the target is the alveolar space, not the trachea, not the bronchi. So that the pulmonary dose reaching infected bronchiole and infected alveoli is much less than the initial dose you inserted into the nebulizer. At this time, you will have some systemic absorption and urinary excretion. And a part of the aerosol is going back to expiration. And tracheal suctioning, if you do it during or after the nebulization period, will eliminate some doses. Okay, you know, nebulization of antibiotics started 50 years ago. It's not a new topic. 50 years ago, less than 2% of the dose inserted here reached bronchial and alveoli, because it was not understood what were the conditions of optimization of nebulization. What has changed recently is that requirements for reaching the deep lung during mechanical ventilation have been perfectly studied and understood. So today, if you are aware of what should be properly done, 40 to 70% of the dose inserted here can reach the infected lung. Okay, what are the specific ventilator settings that should be adopted during the nebulization period, again, for avoiding inspiratory flow turbulences? It has been well described by many studies, and this is one of the review studies. It is 20 years old study, 1992. First, you should decrease the inspiratory flow and use volume control with a constant inspiratory flow. Why? If you use a decelerating flow, at the peak flow, a lot of turbulences. What you should do is if you are spontaneously breathing, your inspiratory flow is maximum at the beginning of the inspiration, minimum at the end of the expiration. A lot of turbulences. On your pharynx, lot of turbulences. So the use of nebulized antibiotic in spontaneously breathing patients doesn't work, because all the dose is going to pharynx, trachea, bronchial tree, not to the infected alveolar space. It's exactly the same if you use a pressure support with a decelerating flow, and so on and so on. Should use a low respiratory frequency, 12 breaths per minute, in order to increase the duration of the inspiratory flow. A high I ratio, same reason, increase the inspiratory flow. Low and constant and long duration inspiratory flow. Then you should end the inspiration with a plateau pressure. If expiration is going back, then aerosol particles are going back immediately. So you should stop the inspiratory flow with an inspiratory pause so that the aerosol particle can stay in the alveolar space. You know, all these ventilatory settings are unphysiological. And most of patients do not like it when they are spontaneously breathing. So they disconnect, they disadapt, desynchronize with the ventilator. And so generates turbulences, and you lose the benefit of these inspiratory settings. This is the reason why, if you want to be efficient, then a short duration sedation during the nebulization period should be adopted. Okay, now come the question, the critical question: what should be the rationale for determining the dose of nebulized antibiotic? What we are proposing is the following rationale. It comes from animal studies I'm going to describe. The dose entering the respiratory system at the end of the endotracheal tube should be equal to the dose entering the trunk of the pulmonary artery. Means that the dose delivered to the tracheobronchial tree should be equal to the intravenous dose. This is a good rationale. Therefore, the dose in the nebulizer here should be the dose delivered to the tracheobronchial tree plus extrapulmonary deposition, that is, the dose of antibiotic deposit into the endotracheal tube, the connecting tube, to the Y-piece. Okay, so before going to humans, we started 15 years ago experimental studies. And we decided to use big animals whose cardiopulmonary physiology was close to human. What is the meaning of giving aerosol to mice or to very small animals whose tracheobronchial tree is very different from humans? The number of division, the size of the animal, it's very easy to get the distal lung in very small animals. Imagine what would be to give nebulized antibiotic to an elephant. It would be much more difficult to reach the deep lung than in humans. So it's small animals are not relevant to understand what should be done. So the reason why we set up an experimental ICU with big animals, piglets, pigs. So it was 15 years ago, before using nebulized antibiotic in humans, big animals, prolonged mechanical ventilation. And the advantage of this model was to be able to sample the lung after giving nebulized antibiotic to assess pulmonary concentration of antibiotic, bactericidal effect. So this is the model. It was giving, doesn't work. Okay, so there will not be videos. Okay, so we anesthetized the piglets, 20 kilos. We gave them mechanical ventilation for 1 to 4 days. And after a period of stabilization, they were in their physiologic position. We inoculated in middle and lower lobe known amount of solution containing high concentration of E. coli or Pseudomonas aeruginosa. It's not ventilator-associated pneumonia. It's a model of inoculation pneumonia. Okay, at the end of the experiment, we killed the animal by exsanguination. In fact, we used exsanguination to get rid of the systemic concentration of antibiotic contained into the pulmonary circulation. And we performed multiple hilar and juxtapleural lung tissue sample for histologic, bacteriologic analysis and measurement of antibiotic tissue concentrations. So I'm going back to the first slide. Did experimental studies confirm the potential benefit of nebulized antibiotic? For the first question, yes. We could get very high tissue concentration in the infected lung parenchyma. In these experiments, we could limit extrapulmonary deposition to 30 to 40% by optimization of ventilator setting, and 10 to 20% of the dose inserted into the nebulizer could reach the infected lung parenchyma of our experimental animals. We did that for amikacin, ceftazidime, and colistin. The second question is also yes. With this very high tissue concentration, we could get patent and very rapid, surprisingly rapid bactericidal effect in animals with inoculation pneumonia. This was true for concentration-dependent antibiotics, amikacin, colistin on gram-negative bacteria. It was also true for time-dependent antibiotic like ceftazidime. Let's see now some of these results. So initially, we inoculated high concentration of sensitive Escherichia coli to our animals, and we compared nebulized amikacin and intravenous amikacin. According to extrapulmonary deposition, we could measure by washing out all the expiratory circuit the amount of amikacin that was deposited in ventilatory circuit endotracheal tube, and then we compare 45 to 15 milligram per kilo, because in this initial study, the extrapulmonary deposition was nearly 60%. So this is the amikacin lung tissue concentration expressed in mic per gram of infected tissue that we obtained in different lobes, upper, middle, and 6 dependent or non-dependent segments of lower lobes. The dashed line here is the minimal inhibitory concentration, 50, of Escherichia coli for amikacin. Look at the concentration. By aerosol, we were in every segment, even in the most dependent, non-ventilated segment of lower lobes, largely above minimal inhibitory concentration. It was not the case with intravenous amikacin. It is well known that when you give aminoglycoside by the parenteral route, never reach the lung, normal or infected lung. It is well known. So giving intravenous aminoglycoside to treat pneumonia is probably an illusion. This high concentration, very high concentration compared to minimal inhibitory concentration, were associated with a very potent and rapid bacterial killing. This is the Escherichia coli lung tissue concentration expressed in colony-forming unit per gram of tissue. 10, 10 to 2, 10 to 3, 4, 5, 6. Okay, and this is now the aerosol group. Each triangle is one pulmonary sample in a series of animals. So after 24 hours, 2 administrations of amikacin at this concentration, 80% of lung segment in the aerosol group were sterile. In the IV group, no difference with the control group that did not receive any aminoglycoside. This was very encouraging. Second model was the inoculation pneumonia caused by Pseudomonas aeruginosa was partially resistive to ceftazidime. That is, the minimal inhibitory concentration were between 4 and 16 mic per ml. In other words, when you get this antibiogram in clinical practice, you do not use ceftazidime. The same representation. This is a ceftazidime trough lung tissue concentration. Ceftazidime is a time-dependent antibiotic. So what you have to do is to be all the time above minimal inhibitory concentration. With a concentration-dependent antibiotic like aminoglycoside, if you reach once a day very high concentration, you kill all the bacteria and you have a post-antibiotic effect. There is no growth of bacteria after the initial high concentration. So we had to give nebulization each 3 hours of ceftazidime to these animals to be sure that we will be above minimal inhibitory concentration. This is a minimal inhibitory concentration for sensitive Pseudomonas aeruginosa. And this is the minimal inhibitory concentration of the bacteria we inoculated to these animals. The mic was 16 mic per ml, okay? So partially resistive. Intermediary sensitivity. As you can see, in all segments of the different lobe of the animals, we were far above sensitive mic and partially resistive mic. In other words, this model seems to indicate that even with partially resistive Pseudomonas aeruginosa to ceftazidime, you can reach bactericidal concentration by using the inhalation route. With continuous intravenous infusion of ceftazidime at a dose of 100 milligrams per kilo, we were above the sensitive mic, but far below the intermediary resistive mic. What was very surprising for us is that the bactericidal effect of ceftazidime, again, it's a time-dependent antibiotic, was very rapid, because after 1 day of administration, 8 administration plus 1, again, 90% of pulmonary segments were sterile. With intravenous route, it was not different from the control. Because we have inoculated partially resistive Pseudomonas aeruginosa. In another study, we inoculated sensitive Pseudomonas aeruginosa, and in the intravenous group, we could reach 60% of sterile segment after 1 day of administration. So it means that in clinical practice, the intravenous administration of ceftazidime is efficient to kill very rapidly sensitive Pseudomonas aeruginosa. The third experiments were by the same model, inoculation of Pseudomonas aeruginosa partially resistive to ceftazidime, but then we used colistin, either intravenous with a 4,000 international unit per kilo compared to nebulized colistin with 56,000 international unit per kilo, because in this experiment, the last one, we had only a 30% extrapulmonary deposition. We learned how to optimize nebulization. Colistin for Pseudomonas aeruginosa is a concentration-dependent antibiotic. So we used 3 administrations. In the intravenous group, we could not detect in any of the segments and pulmonary lobe the presence of colistin. In the nebulized group, concentration observed in the different lung segments were largely above or equal to the minimal inhibitory concentration that was 2 milligram mic per ml. So it was a surprise for us to see that intravenous colistin could not be recovered in any of the lung segments. And in terms of bactericidal effect, we had exactly the same. After 24 hours of treatment and 3 nebulization, here, 80% of lung segments were sterile. There was, of course, no difference between intravenous colistin and control animals. Of course, in this experiment, we looked at the effect of lung aeration and the stage of bronchopneumonia on, for instance, amikacin lung tissue concentration. In this experiment, we check in pulmonary segments where aeration was very low or middle or relatively preserved. It depends on the stage of bronchopneumonia. As you can see, the lower lung aeration, the more extended stage of bronchopneumonia, the lower tissue concentration of amikacin. But if you look at the number, we are even in consolidated part of the lung much higher than the minimal inhibitory concentration of amikacin. So one message of this experimental study is that you should start as early as possible before you get very large and extended consolidation. This is now the histological grade of bronchopneumonia. This is the colistin lung tissue concentration in mic per kilo. Again, in mild foci of bronchopneumonia, you have a high concentration, much higher than the minimal inhibitory concentration. And in consolidated lung, you are much lower. What about the third question? You know, the potential benefit could be to reduce systemic toxicity by using the nebulization route. Unfortunately, in this experimental study, we could not confirm that systemic toxicity was lower than using the intravenous route. Why? In fact, in the normal lung, the alveolar capillary membrane offers a difficult-to-cross barrier for systemic diffusion. But when there is lung infection, there are probably injury of the alveolar capillary membrane that is becoming permeable to antibiotic, and then there is a systemic diffusion. We could demonstrate this for amikacin and ceftazidime. There is one exception, and it is very interesting in terms of clinical practice. Colistin, which has a very low systemic diffusion, even in presence of severe inoculation pneumonia. Now, colistin is a very complex antibiotic. It is made of 5 different molecules, big molecules, and according to this experiment, it has great difficulties to cross the infected alveolar capillary barrier. This is one experiment we made. Healthy lung here, receiving nebulization of amikacin. This is the amikacin plasma concentration, and this is the infected lung. As you can see, at the initial phase of nebulization, there is a small and short and not very high systemic diffusion. When the lung is infected, there is a high initial systemic diffusion, and at the end, trough systemic concentration, that are the concentration involved in the renal toxicity, are exactly the same, around 2 micrograms per ml. In fact, in healthy lung, 60% of the administered dose was eliminated in the urine for 2 or 3 days. In the infected lung, 74% of the dose was eliminated in the urine. So in other words, lung infection creates an abnormal permeability of the alveolar capillary barrier, providing systemic diffusion. What about repeating nebulization? Do we get some systemic accumulation? This was 3 daily administration of 45 milligrams per kilo of nebulized amikacin. As you can see, the trough concentration remain identical. So when you are using 3, 4, 5 daily nebulization of aminoglycosid, you don't get systemic accumulation. But you have trough concentration that are exactly the same as the one you get after intravenous administration. It was the same in the urinary elimination, showing that there is no accumulation. Were there some tissue accumulation in the lung? No, because this is a different segment of different lobe of animals with inoculation pneumonia that received daily amikacin concentration, 1 dose, 2 dose, 4 dose concentrations into the lung do not increase. What about the comparison between aerosol and intravenous? As you can see, with intravenous administration of amikacin at the initial phase, you have a very high concentration, higher than when using aerosol, but then curves are exactly similar and the trough concentration are the same. So from this experimental study, there is no evidence that you can decrease amikacin renal toxicity by using the inhalation route. What about nebulized and intravenous ceftazidime? It's exactly the same. This is the ceftazidime trough plasma concentration, mic per ml, here, according to time, hour of administration. Each 3 hours, we gave nebulized ceftazidime. This is the continuous intravenous infusion. There was no difference between this concentration and the concentration obtained by intravenous administration of ceftazidime. So again, we could not demonstrate any significant trough systemic concentration of ceftazidime between intravenous and nebulization routes. Exactly the same for colistin. This is intravenous dose, aerosol, the dose, and if we look at the maximal concentration of colistin, it was much lower after aerosol, but the minimal concentration was very low and identical. In other words, the initial concentration is higher by the intravenous route, but the intravenous trough concentration remains higher after aerosol. So this is the exception. In fact, using nebulization for colistin reduces systemic diffusion and systemic toxicity and probably the renal toxicity of colistin. Okay, just to end this part of the talk. So experimental studies in big animals were very encouraging for us. High tissue concentrations in the infected parenchyma providing rapid and efficient bactericidal activity. There was one requiring condition, optimization of nebulization. Doses adapted to extrapulmonary deposition. You know, in clinical practice, how to deal with that? You have one ventilator, you have your tubing, always the same. So once you have to wash out your circuit, the endotracheal tube you are using, to determine the proportion of dose that is impacted according to your ventilatory setting. And then you should determine the dose, nebulized dose, as the intravenous dose plus what you have measured in your circuit. You do it once, and then using exactly the same ventilatory parameters and respiratory circuit, you can be sure that you are providing the good dose. Aminoglycosid and cephalosporin systemic toxicity was not reduced by nebulization, but for intravenous colistin, we could not demonstrate after intravenous administration that it could diffuse into the infected lung parenchyma. But even with severe lung infection, systemic diffusion was very low, so there is a hope that we can decrease renal toxicity. Okay, let's move now to clinical studies. We have a lot of clinical studies. Most of them are retrospective, descriptive, with no rationale for the dose, without any optimization of the nebulization system, combining different antibiotics. We have many studies, but very few of them are really contributive to assess whether or not we can get some benefit from nebulized antibody. The first study was published now 5 years ago in Critical Care Medicine by the group of Palmer. It was a double-blind study. This was very important because it was blinded. That is, the medical doctors did not know whether the inhaled dose was antibiotic or placebo. And it was a double-blind study against placebo combining intravenous and nebulized antibiotic. What the authors included was ventilator-associated tracheobronchitis. They didn't perform bronchoalveolar lavage or in a few patients only. They had only quantitative analysis of tracheal secretion. They gave either vanco and gentamicin according to the bacteria isolated in the tracheal sample for bacil gram-negative bacteria or cocci+. There was an intravenous administration of antibiotic in both groups, and in one group there was an addition of aerosol, either of vancomycin or gentamicin. So this is the intravenous plus aerosol antibiotic group, only 19 patients, not a large series. And this is intravenous antibiotic administration with a placebo as nebulization. You know, at the first day of the treatment, the same proportion of patients had ventilator-associated pneumonia. At the end of the treatment, when combining intravenous and inhaled antibiotic, only 35% had still criteria of ventilator-associated pneumonia. 79% in the intravenous group had still, at the end of the treatment, criteria of ventilator-associated pneumonia. Okay, this result is maybe a little bit too optimistic. What they found is that in the group receiving intravenous antibiotic plus placebo by the inhalation route, the quantitative bacterial count in tracheal aspirate was not different at baseline. It was different at baseline week 1, week 2, but there was still a high proportion of tracheal aspirate positive to high concentration of bacteria. In the aerosol group, virtually no tracheobronchial aspirate were positive after 1 week or 2 weeks of treatment. What is very important is that in the aerosol group, they didn't find any microorganism resistive to the treatment that was given. In the intravenous group, 33% of positive tracheal culture here were resistive to either vancomycin or gentamicin or both. Okay, this is the first study, short series, suggesting that combining nebulization and intravenous administration might be associated with a benefit. For me, it is not extremely convincing because this study has an obvious methodological limitation. So we perform a second study, a randomized phase 2 trial. We compare nebulized versus intravenous antibiotics for treating ventilator-associated pneumonia caused by Pseudomonas aeruginosa in a series of critically ill patients. We asked a single question. If we give all the antibiotic by the nebulization route, is it as efficient as giving these antibiotic by the intravenous route? Do we have some benefit? So again, the rationale for determining the nebulized dose was the one I described in animals. This dose, entering the respiratory system, was equal to the intravenous dose. So, the dose in the nebulizer was a dose delivered to the tracheobronchial tree plus extrapulmonary deposition. We used always the same ventilator, the same respiratory circuit. The nebulizer was inserted into the inspiratory limb. We washed out all the circuits to determine extrapulmonary deposition, and so we adopted equivalent dose by nebulization and intravenous route. So we included a series of patients infected by Pseudomonas aeruginosa. 25 were randomized to aerosol of ceftazidime and amikacin, and 25 to intravenous administration of the same antibiotics. Ceftazidime in the aerosol group at the dose of 15 milligrams per kilo each 3 hours was given during 1 week. And it was the same in the intravenous group by continuous intravenous administration. If in the intravenous group Pseudomonas aeruginosa was resistive to intermediary to ceftazidime, we used imipenem. If Pseudomonas aeruginosa in the aerosol group was intermediary to ceftazidime, we didn't change the dose of ceftazidime, just to check whether we could get the same result as we got in the animals, that is, we are able to cure Pseudomonas aeruginosa intermediary to ceftazidime. In both groups, we gave 3 days of amikacin, either by inhalation, 1 daily aerosol, either by the intravenous route. Or if Pseudomonas aeruginosa was intermediary, we used ciprofloxacin or phosphocin. We excluded patients with positive blood culture. It doesn't seem wise to treat a systemic infection by nebulized antibiotic. We excluded patients with extrapulmonary infection for the same reason. And we excluded patients in whom Pseudomonas aeruginosa resistive to ceftazidime and or amikacin was recovered. We perform a CT scan before starting treatment, pharmacokinetic of amikacin during the first day of administration, first bronchoalveolar lavage. On the 3rd day of administration, again, pharmacokinetic of amikacin. And then on the 4 days, pharmacokinetic of ceftazidime, another mini bronchoalveolar lavage, a 3rd bronchoalveolar lavage, a new CT scan just to be sure that we had really improved the lung infection, a fourth bronchoalveolar lavage, and at day 14, a fifth bronchoalveolar lavage, just to see, to be able to analyze the recurrence of Pseudomonas aeruginosa. And the aims were resolution of lung infection, clinical biological sign, CT lung reaeration, CT decrease in lung tissue, that is an indirect reflect of lung infection, and the duration of mechanical ventilation. The number of patients included was not targeted to assess even duration of mechanical ventilation, but also mortality rate. So finally, 46 patients were included, 11 were secondary exclusion, 20 were treated by intravenous amikacin and ceftazidime at a dose of 15 milligrams per kilo during a 30 minutes continuous administration on a daily basis. And ceftazidime was, after a bolus dose, was given at a dose of 90 milligrams per kilo using continuous intravenous administration. 20 patients were treated by nebulized amikacin and ceftazidime. The dose was 25 milligrams per kilo because the extrapulmonary deposition was limited. For ceftazidime, we used 120 milligrams per kilo per day in 8 30-minute nebulization, and we used vibrating plate nebulizers. What were the comparative efficiency of intravenous and inhaled antibiotic in this study? Just remember that we randomized ventilator-associated pneumonia caused by Pseudomonas aeruginosa, either sensitive to ceftazidime and amikacin or intermediary in the aerosol group. So there was no difference between the cure of intravenous and aerosol, even if 70% of patients in the nebulization group were cured versus 55. Failure, 15 versus 30%, and the ventilator-associated pneumonia caused by superinfection were exactly the same. That is, after initial cure of ventilator-associated pneumonia caused by Pseudomonas aeruginosa, we had another pneumonia caused by another bacteria. In the 6 patients of the intravenous group with persisting VAP, 3 were infected by Pseudomonas aeruginosa intermediate to amikacin and or ceftazidime. What about the clinical effect on evaluated on clinical pulmonary infection score? We had exactly the same evolution, even if in the intravenous group the CPIS was slightly above the CPIS of the nebulized group. So in terms of clinical efficiency, it seems to be similar. If we look now at the lung computed tomography, the increase in gas volume between day 0 before antibiotic and day 8 after the end of antibiotic treatment, it was exactly the same. And the decrease in lung tissue, which is a reflect of infected lung regions, were the same. But as you can see, in the aerosol group, there was higher lung tissue than in the intravenous group, attesting on the fact that probably patients were more severely infected in the aerosol group. This is an example. No, this just tells you that by giving nebulization for treating a 53-year-old patient with ventilator-associated pneumonia caused by sensitive Pseudomonas aeruginosa, you can get rid of lung infection. This is a rough images with a consolidation of both lower lobes before the beginning of the treatment. This is a color encoding system. Red is telling you there is no more aeration. And at the end of the treatment, as you can see, there is a marked reaeration. So it is interesting because it confirms that what we observed in animals, even in very poorly aerated lung regions, nebulization of antibiotic is able to reverse lung infection and reaerate the lung. There was a huge increase in lung aeration, nearly 1 liter, and a significant decrease in lung tissue, attesting of the control of lung infection. Another patient of this series, very interesting. In the nebulization group, we had 6 patients whose Pseudomonas aeruginosa had a minimal inhibitory concentration of 16 mic per ml, intermediary sensitivity. And they were treated exclusively by nebulization of antibiotic. In the intravenous group, when we had this intermediary Pseudomonas aeruginosa, we switched ceftazidime for imipenem or for phosphocin or for ciprofloxacin. This is a 32-year-old patient suffering from multiple trauma and a very severe lung infection before starting antibiotic. It was caused by partially resistive Pseudomonas aeruginosa, and after nebulization, a nice improvement. So in 6 of these patients, we were able to demonstrate that giving nebulized antibiotic can be very efficient to treat intermediary sensitivity Pseudomonas aeruginosa. So it confirmed the experimental results. We didn't find any difference in amikacin trough concentration, which determines the renal toxicity. At day 1, this is the amikacin trough concentration, or at day 3, the end of the treatment, confirming what we had observed in experimental animals. What about the bacteriological result? They are quite interesting. Now, 20 patients were included, treated by intravenous ceftazidime and amikacin. At day 0, all patients had a bronchoalveolar lavage. At day 3, 16, day 5, 15, and so on. Okay? Look, at day 5, 8 patients had still Pseudomonas aeruginosa present in the bronchoalveolar lavage, attesting of the difficulties to get rid of the bacteria in the alveolar space when you are giving intravenous antibiotic. At the end of the treatment, 6 had still positive bronchoalveolar lavage. And more frightening, in this series, at D5, 3 of the 8 Pseudomonas aeruginosa that were recovered in the bronchoalveolar lavage had become resistive to ceftazidime and or amikacin. And then at day 9, failure was caused by resistive bacteria. In other words, in this study, because we performed sequential bronchoalveolar lavage, we could demonstrate what we observed in clinical practice, that is the paired treatment occurrence of resistance to antibiotics. In the intravenous group, the situation was very different. You see that Pseudomonas aeruginosa was eliminated. At day 7, only 2 patients had still some Pseudomonas aeruginosa in the bronchoalveolar lavage. The fact that the diffusion, the systemic diffusion of colistin, look in the aerosol group, here in the experimental study, we could not detect colimycin in the blood. So the idea that you can increase the dose without systemic diffusion and getting some systemic toxicity was the rationale for, in this clinical study, administering 100,000 international units per kilo. So it was a monocenter, prospective, non-randomized observational study. It took for us 4 years in our 26-bed ICU to get all the patients. It was a non-inferiority study on cure rate of VAP caused by multi-drug resistive microorganisms. And in this study, non-inferiority of nebulized colistin was demonstrated if the lower limit of the one-sided 94 confidence interval for a difference in clinical cure rate was more than 16%. It came from the idea that by intravenous antibiotic, you get from the existing literature around 50% of cure rate. Okay, so 220 patients with VAP caused by Pseudomonas aeruginosa or Acinetobacter baumannii were prospectively included in this study. There was 153 VAP caused by sensitive Pseudomonas aeruginosa or Acinetobacter, and 69 caused by multidrug resistive Pseudomonas acinetobacter. In fact, in this patient, we do not have any other option than intravenous colistin. Some patients were included for various reasons in each group. So finally, we compare patients infected with sensitive Pseudomonas aeruginosa, treated by a combination of adapted antibiotics, to 43 patients with multidrug resistive Pseudomonas aeruginosa or Acinetobacter that were treated by nebulized colistin. In 28 patients, nebulized colistin was administered in monotherapy because it was the only possibility. And in 15 patients, it was combined with intravenous aminoglycosides. But we know that intravenous aminoglycosides do not penetrate in the lungs. So, in fact, I think these patients were exactly equivalent as these patients in terms of treatment. The first result is, of course, you know that patients with sensitive Pseudomonas and Acinetobacter baumannii are much less severe in terms of duration of mechanical ventilation before administration than patients infected with multidrug resistive drug. They are much more severe patients in terms of duration of mechanical ventilation, length of stay in the ICU, previous antibiotic administration, previous antibiotic use, tracheostomy, for instance, and number of ventilator-associated pneumonia. In fact, this group of patients has a very high severity. You know that. So we observed a similar cure rate at day 14. We gave the antibiotics during 2 weeks. 67% for Pseudomonas aeruginosa, resistive to all antibiotics, 100% for Acinetobacter baumannii. It was exactly the same efficiency as in sensitive groups. This is the clinical infection pulmonary score in both groups. The nebulized group is here, but there was no statistical difference. So in fact, you get with single nebulization of colistin, you get an efficiency that is similar to the intravenous administration for VAP caused by sensitive Pseudomonas aeruginosa. Very interesting. It's a very interesting result. No recurrence after initial cure of VAP was observed in 26% of patients with multi-drug resistive Pseudomonas aeruginosa, never observed in patients with Acinetobacter baumannii. And we know that. It means that for reasons that are not fully understood, Pseudomonas aeruginosa probably staying in reservoirs is able to regularly infect the lung even if you get rid of it by antibiotics. It's not the case with Acinetobacter baumannii. You know, the Acinetobacter baumannii resistive to imipenem is a very severe infection, but it is easy to treat by nebulized colistin, and it does not relapse. This is an example of a patient with resistive Pseudomonas aeruginosa successively treated by nebulized colistin. As you can see, there is a huge reaeration with a huge reduction of consolidation. And this is a failure, because sometimes you are not successful. You don't know exactly why, but you know the success rate was only 67% in Pseudomonas aeruginosa. This is a patient at day 14. You have exactly the same lung infection in both lung. And here you have some over-distension. This is very interesting to see that. In terms of renal toxicity in patients treated by nebulized colistin, there was no difference in peak concentration. We found a significant difference in trough concentration. The trough concentration in the nebulized group was lower than in the other groups, and there was, this is the serum creatine clearance. There was no difference between serum creatine clearance between sensitive and resistive groups. Okay, so the conclusion of this study combined with other study, but again the other study are difficult to interpret, that high doses colistin can be nebulized with good clinical acceptance. We had no deleterious effect that imposed stopping the nebulization without renal toxicity. The cure rate for Pseudomonas aeruginosa is 67%, and a similar result obtained in that caused by a sensitive strain. 100% for Acinetobacter, without any recurrence. The recurrence for Pseudomonas aeruginosa was 30%, 1/3 of patients. And finally, at the time of today, the date of today, we can say that inhaled antibiotics provide more rapid bacterial killing and similar clinical efficiency for treating ventilator-associated pneumonia. Intravenous antibiotic that was suspected from our clinical practice often induces rapid resistance to various microorganisms and particularly Pseudomonas aeruginosa. Probably inhaled antibiotic can prevent per treatment acquisition of resistance because the concentrations are very high and too high to induce and to select population of microorganisms that are resistive to the antibiotic. And if your bacteria, Pseudomonas acinetobacter, is resistive to all drugs, then you can efficiently get treatment by nebulized colistin. What we need today is a multi-center randomized study targeted to ventilator-associated pneumonia caused by multidrug resistive Pseudomonas aeruginosa Cinetobacter to see whether these results are true for large series or if we do not have a reason for using nebulized antibiotics. So this study is under construction, and we will probably wait for 2 or 3 years to get the answer. Okay, so thank you very much for your attention. Yes.